Should we get started? Okay, let's introduce the next panel here, which is our higher education panel. And our speakers are Elisabeth Heath from the Karmanos Cancer Institute, Jose Alberto Torres-Ruiz from Ponce, and Cynthia Warrick from Stillman College. Great to see you guys. Let's have a seat. Okay, well, I presume you heard the prior discussions, and we talked. A lot of the issues that I think will be near and dear to this group came up in the prior two panels. Why don't we start by you introduce yourself and tell us sort of what you think is the biggest challenge in your world for promoting health equity with regard to access and innovation.
First of all, thanks for having me, and I'm going to scoot up here because, as you can tell, since I've met some of you on Zoom, I'm vertically challenged, so I'll sit up, not to block these guys' view. Thanks for having me. Again, I'm Elisabeth Heath. I'm a professor of oncology. I'm a practicing medical oncologist in Detroit, Michigan, and I'm also the associate center director for translational sciences at the Institute. So I get to harass everyone, Ned. It's awesome. But in my practice of 19 years there, primarily of GU patients, I run a lot of clinical trials, have been a principal investigator of 2 numerous to count studies, and have been privileged to take care of a lot of patients, as you can imagine, in Detroit, very underrepresented. I also want to highlight that, you know, we talk a lot about African Americans and whites, but in where I practice, I also have a lot of Middle Eastern patients, as Dearborn, Michigan is one of the largest areas outside of the Middle East to have Middle Eastern folks. So they also are in our catchment area. But thank you for having me here.
Hi, a privilege to be here. I am Jose Torres-Ruiz. I am the Chancellor for Ponce Health Sciences University. This is located in Ponce, Puerto Rico. So we are, as a health sciences university, we have different programs in that area besides the traditional MD degree. Our contribution to cancer is done by funding through the NIH and the Department of Defense. We have U54 in collaboration with the comprehensive, Eli Moffitt Comprehensive Cancer Center in Tampa. That's going on for about more than 15 years. And we have a grant from the Department of Defense for prostate cancer, which happens to be is very timely because Puerto Rico is experiencing a high rate mortality in cancer, in prostate cancer. This is something very unique of the island. And then we have the RCMI program, Research Center for Minority Institutions. This is funded by the National Institute of Minority Health and Health Disparities. And if you ask me about the gap in addressing health disparities, I would say access to care is critical. And there are many reasons why. It's multifactorial. Everybody knows the quality of the service that the patient will receive depends on this insurance. And Puerto Rico is in a big economical crunch right now. 40% poverty, benefits from Medicare and Medicare and Medicaid is capped. We get about close to 50% what the rest of the nation gets. I mean, Puerto Rico and the territories, Virgin Islands and Guam. And very recently, for instance, the Supreme Court ratified the decision of excluding Puerto Ricans living in the island from supplemental Social Security benefits. So it's an economical crunch that has created pressure on the insurance companies, and that permeates into physicians. Physicians, they don't get the compensation, and the result is they are flying out from Puerto Rico to the States. So getting an appointment from an oncologist, another specialist, is a challenge in Puerto Rico right now. So in addition to that, in Puerto Rico, there is an issue with access. The central part of the island, which is the rural part, access to centers where the services are offered are distant and difficult to access. So that's our challenge.
Cynthia.
Hi, I'm Cynthia Warrick. I am the 7th president and first female leader of Stillman College, which is small liberal arts, historically black college in Tuscaloosa, Alabama, founded in 1876 by the Presbyterian Church. We sit on 105 acres of a former slave plantation in the 3 poorest census tracts in West Tuscaloosa. The poverty is greater than 30%, high unemployment, and 96% African American. I would say we're in a food desert, and Stillman, of course, is the healthiest and safest place in the community. We have, of course, the talent and the students. We are small, so we have 800 students. And we have a legacy of producing lawyers and doctors and pharmacists and other type of science backgrounds. I am a pharmacist and a health services researcher. I'm an NIH-funded investigator. And one of the things from the previous panel I was listening to and had to go get mic'd because I couldn't ask a question. But one of the things there were a couple of things that you all talked about. And one in terms of engaging HBCU students, especially in data science. And I think we have a data science program, but we need internships. So HBCUs need internships for students to be in the experiential side learning, of data science, because it's easy for someone to teach data science, but if you're actually not working in data science, and I'm a data person, you're not going to get it. I mean, folks, they start getting nervous over an Excel spreadsheet with just 50 names on it, and that's not big data. So we really do need that kind of experiential opportunities. The other thing, in terms of the food desert, and I really appreciated the comments from Kroger. I have lots of former students. I used to teach in pharmacy school in public health who work at Kroger, and so happy to hear about the great things you're doing. We're in a food desert, and we started a community garden. And one of the things that we want to do with this community garden is develop a demonstration kitchen. Because what we found out is that most of the people in our community, they don't know how to cook. In fact, most of my students don't know how to cook. And so it would be great to have some types of opportunities to partner with organizations to provide healthy meals, especially when we start looking at, what are the things that are going to prevent cancer? And we all know, it's a healthy diet, physical activity, all of these, quit smoking, quit drinking, all those healthy behaviors that we're all supposed to adopt. But, and college is a place where these young people, especially my students, because the majority of them are from first-generation backgrounds, so they don't have the education in their households to teach them what's a healthy meal. So that's what we do on campus with our food service. That's why I say we're one of the healthiest places. But then the other side is, well, how do you make these behaviors take and transition into their own life, when they get married? How do we make this a part of the culture? And I think, we at HBCUs are, the primary place where we could engender those healthy behaviors with help from partners like you. So thanks.
Yeah, Ned, I think I just flunked your first test. I didn't answer your question, so my bad. Strike 2 for Elisabeth. I know one of the things that's happening on the ground, being a practicing physician, is that COVID has completely burned out, I think, the pipeline. And we're not talking about it very much because, people who sign up to be doctors or nurses, they're supposed to want to do this. And what I see in everyone from high schoolers to undergrads to medical students, mostly the medical students, they're a bit lost because they're shadowing us in clinic. You got a lot of disgruntled physicians who are mumbling something unintelligible about the EMRs. Sorry for all the data folks. But you're sitting there sort of slogging through it, and these topics are coming through, and we're listening, but the field has gotten very difficult. So I always refer to one of our surgeons who said, you know, when his dad was a surgeon in the early 1920s, he had everything in his toolkit when he graduated medical school. He knew how to operate. And when this surgeon who's about to retire graduated medical school, he had at least 80% of it and could be around enough to learn the other 20%. These kids now are graduating medical school, and they're lucky to have 30% in their toolkit, and they're learning on the fly. And then there's the rest of us who have been in practice where there's a new something getting tweeted every day. Doesn't matter what field, something in oncology is getting tweeted every day that is new. So if you are relying on the community doctors, who most of them now are somewhat connected to health systems. So at the Karmanos Cancer Center, we're part of McLaren Healthcare. You know, that's 14 hospitals in the state of Michigan. So we're their cancer service line. They're absolutely happy to talk to us, but they're trying to keep up the information boom that is not sustainable. So we want them to be smart oncologists, make sure you know all the data. You know, Eric, you've got Merck, who's 1,000 trials a year. Which trial was that? Which trial was that? And oh, by the way, here's 20,000 other things that you must pay attention to. So we also have a workforce problem, not just so much in the diversity of it, but just in the sheer content of it. So what's happening post-COVID? Lots of people leaving. So I think we're seeing a lot of shuffling in academia that is worrisome, because a lot of them are the leaders who feel that, okay, you know, I can't do anymore, or this is my chance. So you're sort of, it's a terrible time for all this change. And then the young people are looking to us going, what are you guys doing? What are you guys doing? So I think there's a whole issue there that is even bigger than what we're talking about. Because they're not teaching everything we need to know in medical school, let alone keeping up in training, let alone watch out for their own mental health and burnout. And now we're saying, don't forget these 50,000 other things you got to pay attention to. It's becoming more of a challenge as the months have gone on.
Okay, so all three of you have identified problems. And if you could, in a quasi-budget neutral way, you know, not extraordinarily expensive way, propose a solution to your problem. What can you do? How can this be fixed? Is it hopeless? We'll start down here. Cynthia, why don't you go first?
Start with me? Oh, well, I think my solutions are very simple. All of the organizations that are part of CEO Gold and the Cancer and Accelerate Health can provide data analytics internships for HBCU students. It's real simple.
Right there.
Real simple.
That is the wonderfully specific real-world proposal we like here in CEO Roundtable. Thank you. You know, because give Stillman a call if you have an internship for. And by the way, I will say the issue of great data scientists in federal government is really acute. You know, these people are in high demand. They're hard to recruit, and so any training, particularly for diverse data scientists, is a wonderful initiative and really should be seriously considered. How about you? What's Ponce's problem that we can fix?
Well, our situation is complex, but we have been proactive in several ways. One is we have made efforts to increase our capacity for clinical trials. Right now, I believe our unit is the largest in Puerto Rico. And so I have been talking to some people here that there's some protocols that we are interested in. So that's one way. The other is to reach the community. I think this is critical, reaching the community and gain trust. So this trust in science, I mean, everywhere is from the community is something that we have experienced. In our institution, what we have done to reach the community in a more effective way is to recruit leaders from the community, particularly the rural areas, people who are very disadvantaged. And so we invite them to come to the school as leaders, and the way we treat them is as they are colleagues, scientists. They get an email address, they get some stipends, and they are included in the meetings. They are asked about specific problems in the community. And that way we have changed the stigma, this model of distrust. So the leaders go back to their communities and share what they have done, what they have learned, and the way we treat them. And that has improved the participation in clinical trials. Also, we have established the first biobank in the island. We have about 3,000 samples now from different tumors, studying genomics, the markers for the Hispanic community, and with the hope of improving the therapeutics in the future. That was thanks to our collaboration with Moffitt Cancer Center. So at the level of Medicare, Medicaid, that's tougher. That will require tough legislation that requires the Congress to do something about it. But we keep pushing, and we have a commissioner. Unfortunately, Puerto Rico, they don't have senators or congressmen. We have a commissioner in Washington, and she's pushing very, very hard with the Hispanic caucus to get legislation and get a fair share for Puerto Rico.
Fairly specific proposal as well. Very good. All right. How about you? You brought up physician burnout and turnover and a really difficult problem. Is there a solution?
I think there is a solution. You know, I think most of us are in it because we love the science. So I think there just has to be enough time in any faculty or group practice or health system that really will allow the physician to just pause. I think we're lousy at it, to tell you the truth. I think it's nonstop. We're going to keep going until all of a sudden that person's not there anymore because they said it's not worth it. Time to wrap it up. Yeah. You know, so to me, I think getting physicians back on track, whether you're the primary care physician or you're the oncologist, there's, you know, sort of been this turning since March of 2020 that unless you're on the ground with us, you're not seeing it. You're reading about it, maybe we're at conferences like this, but unless you're there in the clinic day in and day out and seeing it and hearing it from patients and our nurses who are probably even more burned out than we are, we have to take time to pause. So in our group, we reflect a lot. Sometimes we just have days where, you know, we end the clinic early. I know health systems don't like that because, you know, that's our views lost. But you have to pause for a second, and we certainly do it when we lose patients. So I think especially in oncology, it's so devastating. I always say I lose a cardiac myocyte every time another patient of mine passes away. But that's the truth because you get connected to them. But I do think the other part of this is the young folks. So although I say they're looking at us going, what are you guys doing? They're the antidote to everyone's burnout because you're not going to tell a young 20-something-year-old, you know, physician to be that you can't do something, that this is not the way to go. They just look at you and go, okay, that's nice. Oh, wow, she's pretty old. All righty. We're just going to move on and do this other thing. And you see it, you know, in the white coat ceremonies where you have all these beautiful eyes looking at you, and they're really engaged and saying they're going to cure cancer. They're going to cure heart disease. And they're not daunted by it. So I think we have tried really hard at Karmanos, at Wayne State, to engage the younger folks in everything, because I think somebody said it, if you're not at the table, you're not understanding the problem. So we tend to be like, let the grown-ups deal with it, we'll let you know. I think that's not the right solution. So we've done more where there's usually a student advocate, a student liaison, somebody that's representing that group, and then getting them engaged to see that this is going to be their problem. All of our hand-wringing with this data stuff now is going to be their problem when we're done. Yeah. Or hopefully not their problem because we're going to fix it all. So.
Yeah. But, you know, one of the issues that, you know, I think about that you brought up, I have 100 biology majors and that all want to be doctors. And we know that it's not going to happen. And one of the challenges that I have within that in terms of filling that pipeline, because we've seen the number of African American physicians, especially male, declined significantly. I think the numbers say there's only like 2% represented today, and that's fewer than even in the 60s. So, we need to really try to develop programs and resources for those students to understand the rigor early on. Because I think what happens, we can't just use organic chemistry and physics as the gatekeeper anymore. We really have to get students earlier, like freshman year, and really try to integrate them into understanding the demand of the health sciences in terms of time and energy, commitment, all of those things, because it's not just collecting a check. I think they don't understand the difference between what a profession is and what a job is. And I think we need to start, especially in healthcare, we need to start sooner than later, not waiting till your junior year when you're going to take the MCAT or the PCAT or whatever. We really need to start freshman year, and we really need resources, because what I see, like I told you about my student population, so 87% are on Pell Grants. Then they have student loans. That doesn't cover their cost of education. Yeah. So they're working. Most of my students are working on jobs, and jobs that are not going to build skills for them to get into healthcare and to be that pipeline. So they're spending all their time making ends meet, sending money back to their family members, helping little sister and little brother, all of that, while they're trying to go to school full-time in order for them to be eligible for federal financial aid. That's what they get. We need some kind of a program that, and I was a beneficiary. The health, HRSA had a health careers scholarship program when I was at Howard. And that supported me. So I didn't have to borrow. I didn't have to work. I could focus on learning and really understanding what I needed to know. And we don't have enough of those programs to really support, undergraduates who are aspiring to become, healthcare providers.
And can I just interject that it should be even before then? Yeah. Mm-hmm. I think it needs to be high school. Yeah. High school is that critical time where you're either hanging with the cool crowd or you're not. And when you get to college, it's different pressures. But a lot of these kids, and we have a signature high school program that my own youngest daughter started that John knows, and what do? We're just exposing kids to different STEM careers. Mm-hmm. STEM careers pay more on average. So it's an opportunity to perhaps lift themselves out of their current situation. But STEM careers are so, huge. I mean, when I say the number one career that has always, year after year, we've had this since 2018, that every student has said, I've never heard of this, I think this is the coolest thing, is a genetic counselor. They've never heard of it. They don't even know what we are talking about. Never heard of it. We have all these students connecting to the actual counselor. What did you do to get this? What are your hours? I really don't want to see blood. Oh, you like talking to people. So the characteristics of what would make that person shine. Some people love data. Some people are like, woo, 10 things on an Excel spreadsheet and I'm done for. But I think if we don't invest in the high schoolers, that's a lost opportunity. So
this is a lively debate, actually. I can tell you at the NIH, two of the NIHs, the National Cancer Institute and NIGMS, support programs that go all the way to middle school, earlier than high school. And it made the arguments that you just made. You got to get them early. That's the time. And, NCI was a strong proponent of that R25 Yes program. But the other NIHs don't like that. They say every dollar we spend on a middle schooler is a dollar we're not spending on our pay lines, and our scientists need funding. And the pay lines at NCI are pretty low. So there's not unanimity on this topic. Is it okay to wait till undergraduate, or do you need to get them in high school and middle school? What do you think?
I think you need all the above. I think
budgets are real.
Well, I think, but see, if we depend just on government, I really think we need industry to step in. I mean, if industry wants data scientists and PhD level researchers, then they need to support developing them. And if they want a diverse workforce, then they need to support developing that, because we can't depend just on government resources alone.
I would say that universities like us, like graduate universities, health sciences universities, they have the responsibility. We cannot depend on the government and rely on the government. One of the things we have we use as a pipeline, as a feeder, is the establishment of binary programs. It's something that alluded to what you talked about earlier. Is we go to schools in the community and they offer sciences, identify good candidates, and we go through an arrangement where those students study 2 years at the college level and then they transfer to medical school. It's called the binary program.
Yep.
So they finish their MD degree in 5 years, basically. So, but it requires an effort and extreme effort. This is not a way of generating money. It's to assure that the workforce of the future is there. It requires, we have to take responsibility.
But I think you also, in terms of the clinical trials, I think you also need practitioner researchers.
Yep.
I think that you just can't produce, the new physician should also be someone interested in research, because that community-based research is so critical, and they have access to the population. Yeah. So I think it has to be easy for them to try to facilitate those types of activities. And I mean, PCORI was established, and I think some things have happened, but I haven't really seen the outcomes of PCORI. Where are the investigators of color who were practicing in these poor communities? Are they part of PCORI, or what are they doing? And so that's where the patients are. That's where the problems are. They're in these underserved communities that, even rural communities that don't have physicians. Yeah. But we need physician scientists.
But I'm not sure people are honest about it. Let's have an honest discussion.
Yeah.
Folks choose a certain career path because academics was not what they wanted to do. So we found this when we were sort of merging our cultures with a health system that is throughout the whole state of Michigan. And this is happening, I think, all around the country. So, the pushback from physicians is like, well, you do you and I do me. So why are we together? Like I should be calling you saying, I'm sending you someone.
Yeah.
But that model doesn't work, because then you're like, well, but they're going to have to travel 4 hours to see me. It'd be better in your backyard. Right, but see, my backyard isn't exactly built for this kind of action. So what are you going to do? And pharma's telling us, oh, no, you can't run that because you don't have this, this, and this. So I don't know how to make that better. That is a real life constraint that I think we have that's ongoing. Just the will. I think somebody said it earlier. If you want this to happen, all parties have to show up and say, yep, that's what I want to do. But when half of your workforce is like, yeah, I'm pretty sure that's not what I want to do, but you're telling me it's what I want to do, but it's really not what I want to do, it's all not meshing up. So the honesty, I don't think, is really there, because if there's a true will, it will happen.
Let's take some questions. I'm going to look at this side of the room because I've had a bias. Anybody over here? Okay, back there. I see waving.
Oh, okay, to hold it down. Okay, so thank you very much for these discussions. I'm going to try to wrap several comments together. Rochelle Ford, president of Dillard University. It's wonderful to see my sister president on the panel. And I think it goes back to the idea of what does partnership look like. It's very easy for us to jump automatically to undergraduate internships. Now, undergraduate internships, need to be paid internships. They not only need to be paid, but if you look at the population, as you heard earlier, Pell Grant eligible students, you need to provide transportation. and housing, because those students will need to be able to care for themselves while they're working at your organizations. And they need to have a wage in which they can save money to help them to afford to go back to school in the fall. There have been programs, as the United States continues to lean into the idea of apprenticeships, we oftentimes think about it at the trade level. We need to reframe it, and if you really want to attack the war on talent with people of BIPOC and other diverse backgrounds, then we need to think about sponsoring them for their education, and as if it is an apprenticeship, or you're taking a program like you see at Northeastern, where the students go to different locations and they are immersed into the corporate environment while they are going in school. So there are new ways to approach industry working together. But partnership doesn't stop at the internship level. You need to invest into the classroom. We can't study big data and analytics without data. Therefore, we need to have opportunities where we have the students sign an NDA that they will not disclose the information, and you provide that data in the classroom. They might be able to mine the data from a Kroger's or from, your labs that you don't have the time to do to make those connections. And look, now you have critical thinking, problem-solving students and faculty who are able to take that knowledge and information and apply it to real life situations. So it's just not the academy thinking and talking within itself. In addition to that, you have to invest into the faculty. We need to make sure that faculty members, whether they biologists or chemists, or they are marketing executives or data scientists, also have the opportunity to be a part of your corporations and have faculty internships. They might be able to see things that your own team members cannot see, whether it's in the summer or even working within the labs. Oftentimes, we go to Research One institutions because that's where the paid researchers are. But if you look at who is educating the bulk of America, it is not the R1s. Most people only get undergraduate degrees. So you need to invest in the faculty who are teaching the bulk of Americans. Furthermore, we can't think just about the traditional STEM disciplines. A lot of what we're talking about is the philosophy of science, where you need to talk about ethics with regards to data. That is not going to be your biology professor. That's going to be your philosophy professor. How many of you guys said, let me endow a philosophy professor? It's not something that we think about. But it's also our marketing, because if we don't involve marketing in these considerations, these conversations, we're going to have circular things. In the same way, how many of y'all have lobbyists that represent you in Congress, and you're saying we can't do this because Congress is not mandating that these things be done? We have students of color who want to study political science and become lobbyists. But if you go on K Street, you will not see people who look like a lot of the guests you invited to be part of this roundtable. So it is not just the STEM, it's the STEAM, it's the politics, it is the economics, and all of your businesses have those disciplines. When you talk about the mis and disinformation, you have to have the influencers. We were joking that you can have, somebody get paid to talk about their flooring. We can use those same marketing dollars and to invest that into influencers who are reaching the African American, the Latino, and other BIPOC communities in which we say we have to fight the mis and disinformation. So it's all of those things that are in partnership. You have to use the storylines, pop culture, the faculty, the government, the political science, the humanities, as well as the internships and reaching out to students. Thank you.
Thank you.
Thank you.
Oh, and my daughter's a lobbyist for AHIP. So she is on K Street.
Any other comments or reactions? All right, let's take more questions. How about over there?
Thank you. Hi, Aubrey Villalobos with NCI. I have one quick comment and then a quick question, I hope, for Elisabeth. The Association of Community Cancer Centers has partnered with ASCO on an initiative to try and increase clinical research capacity in community cancer centers. And I think that the model that was described in a prior session around the study coordinators being sponsored and to help staff up those sites is a great thing to think about more broadly, because they recently did a survey of their membership and found that staffing, that was the critical thing. It wasn't that the clinicians weren't necessarily interested in hosting trials there and conducting research. It was really around the staff capacity. My question is, we've talked a lot about clinical trials and basic science and coming up with new therapies. But we also have a lot of evidence that we know already that isn't making it into practice as quickly as we'd like. And so I'd love to hear your thoughts, Elisabeth, and then also Jose and Cynthia, if you could share, about what data analytics can do, or our software, technology, EMRs, to help clinicians with that burden of being aware of everything and learning and implementing it. How can we speed that up with technology and data?
I think the number one unmet need for any practicing oncologist is, how do I know what trials are available for my patient who I'm just sitting in front of right now? And the eligibility criteria is whether I know them or somebody sitting next to me. Because I run so many and I've done this for so long, I already know. I can see a person and go, those are your top 3, and the deal busters are this one, so I narrowed that. Yep, you get this one. And I hope you say yes. So that's the streamlined version. If that could be put into an electronic database somehow, and there's been many types of softwares that have been presented, lots of attempts, and none of it has really helped. But for the community physicians, what you have out there are folks who sit there and sift through the chart. I think somebody did a pre-screening. That's heavy manpower, woman power, that most of us just don't have any resources to do. So if that was somehow derived from big data, maybe it's genomic sequencing, maybe it's just standard labs, maybe it's from the specialty pharmacy that has shown that you've been on these 3 other meds and now you can get on something else, that would be a game changer for us.
Yeah, I believe the access to data is crucial. Today I was learning about the platform they use, the DataSphere platform, that gathers information about more than 200,000 patients going to clinical trials. That's a tremendous amount of information there, that if our faculty, and now I know how to get it, I just learned it today, but getting into that data will change hypotheses, will create new ideas, will establish new collaborations and partnerships. I think this will make a difference in the way our physicians engage in clinical trials.
Well, we have to wrap up, but I'll give you guys the... go ahead. I was going to give you all the opportunity for a closing comment here.
Well, I'll make the closing comment on her question in terms of access to data, especially for HBCUs and data training. NCI and other federal HHS agencies have put out grant opportunities, and we were a partner with Stanford and Aim Ahead and didn't get funded. Well, who got funded? Well, the one HBCU, Howard. So it's always the same folks getting the funding, and you never get an opportunity to spread the knowledge around, because if and I know I'm Howard alum, so I'm very proud of that, but other institutions have researchers and have interests and partnerships and students who need to be able to develop and learn and get into these research opportunities. So I would say, spread the opportunities around, and don't just focus on the main 3 institutions that continuously get funding when you want an HBCU partner. And I'd like to applaud the CEO Gold for including less known HBCUs in this organization. You chose us first, and we're very pleased, and I'm excited about that.
I will conclude with this statement. I think closing the gaps in health disparities in cancer, it requires a collective effort from multiple disciplines, multi-level research, I think everybody has to put an effort. This is a battle that it requires all of us together to put our minds in the direction of resolving this problem. It's not easy. That's why I am very glad I was invited to this forum, because I see this here, these different views and different disciplines and different experiences.
Elisabeth.
Yes, I completely agree, and just so grateful to be on the panel with you two, and of course you being so experienced. You know, what I hope is that we continue the conversation. I always say community engagement gets us to the next level, but you know, community, we think about it sort of where you live, but this is our community. And I bet you right now there's missing people at this table that should be here that we don't know about. And that's what I think we all should think about today, just who's sitting next to you that maybe should be next to you that isn't here, that doesn't even know that this is happening. So I hope we continue the conversation.
Well, very good. Let's wrap up. Thank you, our panelists.